Examine a clinical pathology report for a neoplasm, and you are looking at dozens of potential coding pathways. The most common failure point for medical coders in Chapter 2 of ICD-10-CM is treating a neoplasm as a purely anatomical problem. They find the body part in the documentation and jump straight to the index. Consistent accuracy requires a three-phase algorithmic sequence: determining behavior, defining spatial relationships, and following a rigid lookup protocol. Bypassing this sequence to code based on anatomy alone leads directly to claim denials and audit failures. This diagram represents the starting node of the algorithm, the neoplasm. At this stage, anatomical location is not yet a factor. The general guidelines specify that while Chapter 2 contains all malignant codes, it also houses most benign codes. This splits our starting node into 6 distinct pathways. The first task is to isolate the clinical documentation into one of these 6 mutually exclusive behavioral classifications. There is an exception for specific body systems. Certain benign neoplasms, such as prostatic adenomas, map to their specific body system chapters rather than Chapter 2. This initial classification establishes the specific logic path that the spatial and indexing rules will follow in the subsequent phases. Within the malignant pathways, the algorithm follows strict sequencing rules. Clinical documentation must definitively identify the primary site of origin and any secondary metastatic sites. In example 1, a patient has primary malignant lung cancer and metastases to the brain. We route the lung cancer through the primary node, yielding code C34.90. The coding guidelines dictate that the primary site is sequenced first. The secondary metastatic site, the brain, is then appended as the second code, C79.31. Sequencing these distinct behavioral codes in this order accurately maps the systemic spread of the disease for the medical record. Once a primary malignancy is identified, the algorithm requires a spatial analysis. A contiguous tumor is explicitly defined as a primary malignancy that grows and overlaps across 2 or more connected anatomical sites. Consider example 2. A primary malignant neoplasm overlapping the esophagus and the stomach. Because these connected sites overlap, the algorithm uses a 0.8 subcategory, unless a combination code exists. Here it yields C16.0. Conversely, non-contiguous tumors are multiple physically separate lesions located within the same organ. In example 3, a patient has distinct malignant tumors in 2 different quadrants of the right breast. Since these tumors do not touch, the rule requires separate codes for each individual site. Physical proximity determines the final code volume and whether a combination code is appropriate. The algorithm contains an exception pathway that can override standard spatial rules. Ectopic tissue is simply cellular tissue found growing in an entirely abnormal anatomical location as a direct result of early embryological development. For these cases, ectopic malignancies are coded strictly to the site of tissue origin, regardless of their current location. Example number 4 describes an ectopic pancreatic malignant neoplasm involving the stomach. Although located in the stomach isn't used for code selection. Because the tissue origin is pancreatic, the logic routes the code back to the pancreas, resulting in C25.9. In Chapter 2, the site of tissue origin remains the governing factor, regardless of where the tumor is physically located. After determining the logic path, the coder must execute the operational lookup protocol. This starts by checking for histological terms, such as an adenoma, a diagnosed sarcoma, or a lipoma in the provider's documentation. If a histologic term is present, you must reference it first in the alphabetic index to identify the correct column in the neoplasm table. Let's apply this to example number 5. A provider documents an adenoma of the prostate. Searching adenoma in the index directs us to the benign neoplasm column, ensuring we land on D29.1 rather than assuming a malignant code. The final step is to verify the code against the specific rules and exclusions in the tabular list. Using the alphabetic index when histology is documented is the only way to maintain the integrity of the behavioral classification. We can now view the completed algorithmic decision tree as a single system. Phase 1 filters the documentation into one of the 6 behavioral classifications. Phase 2 maps the spatial coordinates and applies origin rules for ectopic tissue. Phase 3 executes the index to tabular lookup protocol. As these 5 examples move through the logic gates, the algorithm resolves the documentation into the final verified codes. Following this three-phase framework transforms complex clinical narratives into precise, standardized ICD-10-CM data.